Hey everyone, welcome to the podcast. I'm your host, Dr. Dean Mitchell. Grab a seat, get comfortable. You're about to enter the smartest doctor in the room. Just close the door behind you. Today's title, no, I'm not talking about you, Dr. Katz. Today's title is, when should you see a neurologist? Now, nobody wants to see a doctor, except for maybe the dermatologist, or you're getting a pimple popped or a Botox injection. But what would give you a reason to see a neurologist? If your primary care doctor recommended that you see a neurologist, or you even decided on your own, it must be due to some kind of serious issue. Neurologic diseases range from migraines, headaches, to strokes, to even chronic diseases like Parkinson's. For many years, the lowdown on the field of neurology was that unfortunately there weren't many treatments for a lot of those above conditions, and patients just had to live with that. But that has changed a lot in the last few decades. My guest today is Dr. Amiram Katz. He's a neurologist in Connecticut with over 4 decades of experience. He also has some special training in diving and hyperbaric medicine, but of course in other, bread and butter neurological issues like seizure disorders and sleep medicine and multiple sclerosis. And it's interesting. I reached out to Dr. Katz because we had a few patients in common, and I saw that he was using some interesting therapies. So I really wanted to get him on the podcast to talk about a bunch of things. So again, it's my pleasure to welcome Dr. Amiram Katz to the podcast.
Thank you. Thank you for having me.
Okay. So we talked previously, just for briefly, before we did this podcast today. We both actually trained in Israel at Tel Aviv Medical School in the 80s.
That's
Which
correct.
is kind of interesting. But what's interesting about that time, what I remember also, it was the time before the major breakthroughs in diagnostic radiology, like CT scans and MRIs. We didn't have them. So I was just curious at the time, why did you choose to go into the field of neurology at that time in your career?
Well, at the time, I was kind of looking forward to a career in diving medicine,
Hmm.
and there were two specialties that were linked to diving medicine. One was the pulmonary medicine, which I found to be not so intriguing or interesting.
Okay.
And then there was the neurology with all those peculiar syndromes that you develop with high pressure or decompression. And I thought it would be much more interesting. And the department that I was as close to was really known to be high quality of experts there. So
Oh, wow. That's
that
very
was
interesting.
the reason. Yeah.
Oh,
And
okay.
then indeed I went into hyperbaric medicine down the road, and it was proven a good specialty.
Interesting. Would you say most of your patients come to you from referral by their primary doctor, or are they making their own sort of self-referral due to like pain or loss of sensation?
I think most of them are coming due to referrals by not necessarily by doctors, but by other patients that
So
have
self-referral
seen
from other
me.
patients. Oh, wow.
Yeah.
Okay. That's interesting. What neurological illnesses do you feel get possibly overlooked the most, or misdiagnosed, or the longest delay in getting diagnosed?
Excuse me just a second. I need to
Sure.
shut the door here.
Mhm.
And you were asking what neurological
Yes, what I was
conditions?
asking, I was curious, one of the interesting things, obviously neurological diseases can be very, well, we call insidious, like kind of sneak up on people versus obviously, again, acute stroke or something. But what diagnosis do you feel get overlooked or misdiagnosed the most, or the longest delay in finally getting a diagnosis? I was just curious if something comes to mind.
You know, demyelinating disease, if they're not happening in dramatic pressures like acute attack where you lose some motor strength, etc., They can sneak on you, and you can collect white matter lesions in the brain over years. The other thing is what they call minimal brain changes, like light dementia, which might be secondary to different condition and is being just, ignored and said, I'm getting old, right?
Right. Right. That's what everybody worries about. One that comes to my mind is what's called myasthenia gravis. And for our listeners, you're probably seeing a lot of commercials about it now. I think it's a kind of a rare condition, as you know. But I remember once reading an article actually in like, I think it was the New Yorker magazine about a case of this where it was crazy. Like the patient was getting progressive. It was a young patient. It was a young woman, and she was getting progressively weaker. And she was also having mental changes. And she kept on running to the emergency room several times. Like she thought something was wrong. They thought she was psychiatric, so she kept on getting more and more antidepressants till finally the upshot of the story was she was sitting on the toilet and she couldn't get off the toilet. Her muscles were so weak. The paramedics, everything had to come and get her. And then she was really fortunate. And they admitted her to a psychiatric part of the hospital. And she was so fortunate that the psychiatrist who had, I guess, some neurology training, we're going to talk about that, how there's a little bit of cross training in your field, said, I don't think this is psychiatric. And they brought in a neurologist who evaluated her carefully, thought it was consistent with myasthenia gravis, and then I think it was called the tensilon test. Is that still the test, like where you make the
Not allowed
diagnosis?
anymore.
It's not
Not
allowed
allowed
anymore.
anymore because of
So it's all
side
made from
effect.
a blood. So is it made from a blood test? Like, how do you diagnose myasthenia gravis?
You
That
know,
weakness of the muscles.
so myasthenia is a weakness upon repetitive actions.
Mm-hmm.
So in the EMG lab, of course, if you have serologic acetylcholine receptor antibodies, it gives you a good
It
indication
does.
that might be, yeah.
Do you
But
need a
the
muscle? Do
typical,
you need a biopsy also? Do they have to still do biopsies of? Or does that help, but
no,
not necessarily?
it's not necessary. But the clinical story, the presentation of the weakness is increasing as the day goes on. So the more you do, the
Right.
more
The
you
more
get
tired you
weaker
get.
at
Mm-hmm.
the end of the day. And the people with bulbar ocular myasthenia, their eyelids are drooping as day goes on,
Right.
and they lose a voice, and they have difficulties in breathing. So you can do somebody to give them, take a deep breath up to 30 times, and you can see that it gets weaker,
It's
and the
more
counting
shallow. Yeah.
number, counting number gets slower, like a 14, 15.
Mm-hmm.
And
You
then
know,
the EMG is the ultimate electrical diagnosis of decremental pattern of the
Oh, interesting.
EMG.
So would you say also, like, for example, in a myasthenia gravis case, like, can it sometimes take like 10 years till a person gets diagnosed? Like when you see a patient and you're pretty confident of the diagnosis, and you look back at their history, will you sometimes say, oh my gosh, this patient probably had this 20 years ago?
No, it's 20, but
I mean, 10
definitely
years ago. Let's say
10.
10 years
Yeah,
ago.
yeah, yeah,
I,
that's definitely possible.
And what about I'm going to get to this in the next question, but and what about treatments? I remember, because it has to do with like acetylcholine receptors and everything too. But is there now good treatments for something like this, which is so debilitating?
Yeah, there are definitely better treatments. In the past was only steroids, but steroids can lead to myopathy.
Hmm.
Now we have, and immunoglobulins are very helpful.
Intravenous
And
immunoglobulin, you mean?
yeah,
And
and
what about
biological,
and what about biologics? Because I see something advertised on TV all the time.
biologics are definitely what biologic targeting in the B lymphocytes and destroying them. That's what gets us to remission. So we know that it's a B cell disease making antibodies against the acetylcholine receptor. So you need to terminate this line of cells, and can be done with rituximab or Ocrevus, which is very similar. There are other agents as well, but immune suppression is going to,
That's what works. And does it
yeah,
get them back to like 75, 80% of functional ability?
correct, yes.
It does. Okay, that's great. That's really good news. My next question is, the rap on neurological diseases for a long time, and that's why I was asking why you went into it, was that they are incurable. And, so many patients, of course, are afraid of being diagnosed with one. What conditions would you say today it's different now than when you began your career that can be cured, or ones that can be managed so well that you hardly even know you have the condition? And I'm talking about things like, seizure, epilepsy disorders, or multiple sclerosis. I mean, has there been tremendous advancement in caring for these patients?
Definitely. Talking about seizure disorders, there's so many pharmaceuticals that are now proven to be effective, and but the disorder continues, and if there is a focus of the onset of epilepsy, then surgical options are also possible, removing the focus.
Really?
And now, interesting help is vagal nerve stimulation or other cerebral stimulators
Oh, I
that
like that. Yes, I think it's a very exciting area.
can
Okay.
modulate the brain activity and
Interesting.
quiet it down. Uh, so epilepsy, big progress with this epilepsy surgery and those tools, and MS definitely
What about
new,
cannabis? I'm sorry, the reason I'm bringing that up, because again, as you said, you trained in Israel and I did training in Israel. I know, I remember, I think Sanjay Gupta, who's a neurosurgeon, did a whole thing on that there was like a child in the United States who had terrible status epilepticus, like constant seizures. And the only thing that worked was cannabis, of all things. And I know in Israel, they do a lot of research on that too. Have you ever recommended that or had patients look into something like that?
yeah, with seizures definitely. There's a this, where was it in Charlotte's Web was one of the strains of cannabis that was supposed to be effective against seizures, which are intractable seizures, and that's something definitely worth trying,
Mm-hmm.
because there are not any side effects which are so. Before going into those terrible medication or surgeries, definitely should give a developing child, a child with this particular brand that has the right mixture of CBD and THC.
Really? Has that ever come up in your practice, even with an adult, like where they came and said to you, Dr. Katz, again, they've had to go to the emergency room, they've had a couple of seizures, and they're like, because again, I do functional holistic medicine along with immunology, and people are always asking, what's the most natural thing I can do? Would that ever be a consideration, where you would go that route before treating with a known anti, seizure medication?
Not for seizures, but for other conditions. I would
Yes.
many of them chronic pain
You would
and
for chronic pain issues?
absolutely, and mood disorders.
Mm-hmm.
Uh, we had this. It's legalized now in Connecticut, but before it was legalized,
Mm-hmm.
you can get medical marijuana, and I made many referrals, and
Mm.
found it to be helpful and definitely worth stopping by this option before going further.
It's interesting. I know as a neurologist in your training that you get a certain amount of psychiatric training. Um, and I'm sure in your experience, many of these diseases that are chronic, patients, are dealing with depression. Is that an important aspect that you need to address in your
Very
patients?
important.
I mean,
Very
because
important.
again, you see a lot of these patients with neurological diseases struggling, to have a normal life, and yet we say, oh, well, you have a physical reason to be a little bit depressed, but should they be in conjunction treated with an antidepressant? And are some of them maybe
Absolutely.
better? Yes.
Absolutely, yes.
Mm.
Absolutely. Because I think the problem is that people are afraid of being labeled as psychiatric patients when they have an organic disease, and that brings to suboptimal treatment of their depression and anxiety.
Yeah.
And then it loops back to their organic condition and make other treatments less effective if the depression is governing the patient. So we need to treat with antidepressants. We need to treat with stimulants even to help them get out of this chronic fatigue, which is dominating some of the chronic illnesses. So we need to be aware of those problems to be able to help them pharmacologically.
And, are there any appropriate situations, and I'm sure there are, that where a patient with a neurological disease, or especially an acute one like strokes, should be going to specialized centers, or is it fairly standardized among most? Like, let's say you're in Connecticut. I know there's that Yale New Haven, which is a great one, but there are a lot of very good community hospitals. If someone or one of your patients, or somebody you knew God forbid, had a stroke, would it be really important which hospital they go to get treatment?
In the acute phase, they're about the same. They give the TPA, but their rehab facilities are important to get them to a good
So that's
rehab
more in the
facility.
chronic. So in the
Yeah,
acute phase, you mentioned TPA, just for our listeners, that's tissue plasminogen activating factor, I believe.
right,
And that's to
right,
break up a clot if it's a stroke that's due to a blocked artery
right.
going to the brain.
Within 6 hours of window, and so
Right. So that's pretty standard. But like what you're bringing up actually is actually very important, and then tends to fall in the rehab units, right? Where, patients really go through specialized training. I remember reading once, I think this was years ago, I think it was in Alabama. They were one of the first rehab centers, like when a patient would have a stroke, and for example, if they lost, use of their left arm, what the hospital used to do is they
get
used to tie their right arm
get
or whatever.
The name of the Dr. Tobe.
Dr.
He's the
Taleb,
one who,
right?
yeah, he's the one who developed the interesting, very interesting, and to this date, it's an effective method. And
Is
the
that
other
because of
thing,
the plasticity in the brain? I mean, why does that supposedly work? I mean, you have a limb that's not really useful, and it's tremendously, I'm sure, a struggle for the patient. But what's happening there? Like your brain is trying to send signals to get that moving again?
you force the sick part of the brain to rewire neuroplasticity by he cannot help himself with the functioning limb, so he needs to do something with the non-functioning limb. The brain will send out messages, and they will eventually find some functioning cells in this dead tissue that will enable opening new channels of communication.
It sounds very primitive. Is there any way, like now with like electrodes or something, to stimulate that a certain side of the brain to get that moving to help the patient?
Well,
Or
there is magnetic stimulation, which is used for testing, but there should be more prevalent stimulating techniques that should be
yeah, that should be
available
part
for
of
each
it.
patient.
Yeah.
Yeah, part of the like like tens units that you can put it on the scalp, and small electric device that can move the recovery forward.
Yeah. The field of neurology has always had the reputation that the neurologists were really always, I remember my hospital where I trained with Columbia, were always really quite skilled at the physical exam. It's something I think even neurologists took a lot of pride in. And this was all especially pre, scans like CTs and MRIs.
Right, right.
Do you still feel the physical exam is as important as it was, or have scans really replaced that?
Well, the physical exam is still important, especially if you compare findings from visit to visit and document them.
Mm.
And the imaging studies are mainly static, it's not functional imaging.
That's a
Functional
good
imaging are
point.
still expensive and not approved easily. So you see static image of the brain. It doesn't tell you what's happening from
That's a
the
great
brain to
point.
the muscle.
Yeah, that's a great point. The analogy just for our listeners too, it's like, and I think it's way underutilized. I think it's all has to do about, insurance, which is very unfortunate because, a lot of times patients have, I mean, they can even have angiograms, where they go in and they look at the arteries and the heart and everything, but it's not really showing the flow of blood dynamically what's going on in the heart. You could do what's called a PET scan, right? There's the
Right.
positron emission, whatever, tomography.
Tomography.
And yeah, and that also to me would be very interesting, obviously looking at people's brains. Actually, there was a guy, and you probably heard of this, and I don't know if it was a little bit not as legit, but like the Amen clinics, which you probably heard of. There's that Daniel
Yeah.
Amen, and he was promoting a lot of those, um, which sounded like the equivalent of PET scans, looking at flow in the brain. But is that do anything about those clinics? I mean, I know people spend a lot of money when they go there. It's like
Yeah,
five,
I
ten
think they
thousand
are
dollars.
overreading, overinterpreting, and for example, the softwares that are MRI softwares that are measuring the thickness of the cortex and ventricles, they're coming with terrible diagnosis in normal brains.
Wow, so that's not good. That is not good.
There are no standardized
Uh-huh.
measurements of these, and obviously, the more verbiage they will give there, the more they will have business they will have. They're driven
Yeah.
by business.
I know. It seems like a very expensive clinic, big time workups. Um,
The
you
SPECT
know,
scan, the quantitative SPECT scan is available, and that's a reasonable technique,
yeah.
and insurance
Hmm.
covers it
It
sometimes.
does. Okay, that's good to know.
Because you take the blood flow, measure it, number of pixels per lobe on an atlas of the brain, and then you can say whether this is normal, this is hyper. So the blood perfusion is assessed accurately rather than just telling that
Hmm.
it looks like.
Would you say, again, from all your years in practice, I mean, sometimes it's hard to tell because things can blur from one decade to the next, I guess, but that the prevalence of neurological diseases such as Parkinson's or even ALS or Alzheimer's, are they on the rise, like the way diabetes and cancer is? And, in your opinion, or from you're looking at the
I,
literature,
I think they are on the rise, and I
why do
don't
you
know
think
to
that
what.
is?
I think it's environmental, most likely.
Yeah, that led me to my next question I wanted to ask you. I'll tell you something really fascinating, actually. You might not be familiar because in my training, I'm, also 30 some odd years in practice, and I do immunology and functional medicine. And one of the things I got involved with the last decade was what's called chronic inflammatory response syndrome due to toxic mold. And I know this is not something we really get in our conventional training, so I had to do specialized training with certain doctors that were leaders in the field. And the kind of cases that I am seeing are incredible. And a lot of them have to do with neurological issues. I mean, ranging from headaches to paresthesias, very strange things. Because I guess, the mold causes what's called mycotoxins, which are very
Hmm.
dangerous. We know this from the
Yeah.
military. So I was curious again too, just to, your own um, from your experience or reading articles, there are specific environmental exposures besides that are causing some of these neurologic conditions. I remember they used to ask this on the boards all the time, on medical boards, like Parkinson's is associated with excessive aluminum ingestion. I
Right.
mean, is
That's,
any
I
is any of
think
this
that
true? Is that true?
Alzheimer, yeah, Alzheimer, aluminum, Parkinson
Really?
is,
And where are
and
people getting
BP
this from? From products, you mean, or from ingestion from
from
food?
cooking, cookware,
Really?
yeah. And the Parkinson, there was a contaminant of one of the illicit drugs, a stimulant in the that could ruin the dopaminergic cell, be a toxin to the dopaminergic cell. So obviously, before they were paying attention to what are they spraying the fields with, Phosphoorganic definitely can cause
Right.
damage.
Wow.
And so many environmental stuff.
What about air pollution? I'm finding more and more and being more and more aware of this, that, air pollution. I had a guest on, we were talking about, oh, I know. It was a week or two ago. It was very interesting. It was somebody from the University of Pennsylvania who's in charge of the Taste and Smell Center, and we were talking about how COVID affected it. But he said one of the biggest causes, and we were talking about how loss of smell sometimes predates Alzheimer's by like 10
Alzheimer's,
years,
yeah,
right?
yeah.
But then we were talking, and he said something very interesting. He says, but probably the number one reason he feels people lose their sense of smell is the actual air pollution. It damages
Mhm.
the cells. So I found that
Yeah.
to be fascinating and scary. So all our listeners, go out into nature, get into that park, go out
Right.
by the beach, get the fresh air as much as you
Well,
can,
breathe with the mask,
and
right?
wear a mask. Yeah, I know. You see a lot of Asian tourists or people, I guess, who live here in New York. 'Cause my practice is in the middle of New York City, and I remember this was before COVID. I used to see people usually of Asian background wearing masks. I'm like, why are they doing that? And I guess they were pretty smart. They knew something we
Yeah.
didn't.
And if you remember the first days of the pandemic, first month, there was a drastic decline in other air infections. Flu season, the flu numbers were down. So it means that there is prevention value for those masks.
Something else someone mentioned too, just going back in the history, they said, I think it was the 1918 flu pandemic, that
The
they,
poneconomo,
yeah, that they,
that's okay.
that they saw that there was later on increase in Parkinson's disease. I don't know how they followed that, because that would have taken a lot of resources to track all those patients who really had flu, which they probably didn't even have tests as good as they have today. And then to see later on there was an upswing in Parkinson's like 30, 40 years later.
That's right. That's right.
Yeah.
And yeah, but I think it was not the flu. I think it was the poneconomoencephalitis. It was
Oh, okay.
around
I
the
thought
same
this.
time.
Oh, wow. Well, that one makes more sense too. It's hitting the CNS systems.
Encephalitis, right?
Yeah.
But they
What?
they also found interesting that you are making this connection because they found that an anti-influenza drug, amantadine, they found out it helps Parkinson's disease.
Oh, interesting. Okay, so
And
just
in
for our listeners to.
those old nursing home that they gave it to prevent the influenza, all of a sudden the Parkinsonian patients started dancing. So
Is the
it's
is the
considered
mantidine
to
in those? Is that what's given in the when you get the acute flu? They still give that in mantidine? I think so, right? Or not as much. There's another
yeah,
one.
they
Yeah, they
might
do.
not as much, not as
Yeah,
much,
yeah.
but
I know
but
it is. I used it
it,
actually with my parents once when they got the flu a few years ago. This was before COVID. It worked really good if you catch it
yeah,
really
it works
early.
on the dopamine receptor also, and makes you more alert
Yeah,
and and moving more fluently.
yeah. One other thing too, again, as I said, I deal a lot with natural, medicine as well as conventional. But I always warn patients, natural things can be very dangerous, or even more dangerous are over-the-counter things that people take. I was just reading, there was a story by Lisa Sanders, who's also in Connecticut. She writes the column Diagnosis for the New York Times on Sunday. It was
Yeah,
very good. And she had a case, this was really interesting, of a 70-year-old man who was extremely healthy, walking 10 to 15 miles a day, and he went to being almost like bedbound. And his wife was so worried, and he developed a tremor. And his wife was so worried, she kept on bringing him to the hospital. She was, I think he's having a stroke. And he was admitted and checked out, and they couldn't find anything. And then there was one very smart practitioner, I think it was a nurse though, or a physician assistant, who noticed that he had a constant gastritis, so he was taking 4 Pepto-Bismol a day, and it turned out he had bismuth poisoning.
bismuth poisoning. Yeah,
Yeah. So and then again, get ready for this podcast today. Today in the Wall Street Journal, there's a whole big article on teens' energy drink habit causing seizures, and these kids that are drinking those high octane caffeine drinks that also have ginkgo biloba in it were getting seizures. Have you seen any cases like this? I mean,
I haven't seen it, but
And why would it cause that? The caffeine itself, or is it the ginkgo? Why would they get a seizure
I
from
think
the?
the ginkgo, it's a glutamate activation. I think it
Ah,
boosts the glutamate. I don't think it's necessarily lowers the GABA. I don't think it's anti-GABA receptor, but more pushing the glutamate up.
oh wow. I mean, so again, the public has to realize, again, I just want to emphasize this to my listeners because I've talked about this before, um, that just because you can get something without a doctor's prescription doesn't mean it's safe. And especially
Actually,
if it's in excess. And
many
in
times
fact,
it's not.
I right. In fact, my mantra is honestly that if you're taking something over the counter repeatedly, it's possibly dangerous because you're not telling your doctor, and that could
Right.
be hiding a deeper issue that it's really important that they know. So, because again, I think now more commonly, I know in my intake forms, I'm asking patients, please list the supplements
All,
that you're taking because
all
again,
the
if the doctor
supplements,
doesn't
right?
know, you can't avoid that. So one other thing too, I mentioned earlier in the podcast that you and I have in common a little bit is our use of gamma globulin. I use it probably a little bit differently than you do. I do intramuscular. I know you've recommended it intravenously, which I think has been an underutilized treatment because it is expensive. But tell me some of the cases where you've used that to help patients that might not be the standard use.
Well, you see, when we started the Lyme epidemic, right?
Hmm.
Uh, 20, 25 years ago, and I would see patients that require immune suppression for their treatment, but they have Lyme disease. And even those days, we weren't sure that we are so capable of treating Lyme disease and eradicating. Before we knew that they're persisters and you can never get rid of it. So the drug of choice to get immune modulation without suppression is IVIG.
100%. I want to just you're saying it beautifully scientifically. I just want my listeners to know what Dr. Katz is saying here, that and as he mentioned earlier on too, like when you're trying to sometimes reduce the body's own immune response, which can sometimes be damaging. Obviously, a lot of doctors can write a prescription for steroids, but steroids, as even the layperson knows, have so many side effects that it's just not an optimal treatment. Whereas gamma globulin can do the same thing, but it actually, and again, I know this from my immunology background, it actually increases your immunity. So you're
Correct.
getting a double benefit. But I want to run something by you too. I've talked to a couple other specialists about this, researchers. My take on chronic Lyme disease is not that these patients are actively infected. My take on it is, and I've talked to a couple of researchers on this, is that the cells have some kind of maybe fragments of the spirochete, which is the Lyme bacteria, and that it's irritating the cells so that they're releasing what we call immune hormones, cytokines, and that's what's causing all the pain and disruption. So more antibiotics to me, and there is a whole league of doctors that who are big shots saying give more, 6 months of antibiotics. This too. I think it's a huge mistake. I've been seeing a lot of problems from that. I think
I
it's
agree with
essentially.
you.
Do
I
you
agree with
agree?
you.
That's why I liked what you were
100%.
doing. Yeah, I think something like immune globulin is really great because again, it's knocking down like interferon gamma, which causes this kind of thing. I probably had it this past weekend. I had a really bad cold. I could barely get out of bed this weekend. And I said to myself, this is that interferon gamma in my body, just telling my immune system, hey, go in there and fight. But if my body had to fight for 6 months, I'd be exhausted. So I like the idea because I think I've seen you use that with patients. And I felt like we were two like-minded people
Absolutely.
on this
Absolutely.
topic.
So you get passive immunization, IVIG,
Right.
because that's the drug of choice. It started, people don't make enough antibodies. You give it to them intravenously. So obviously it gives you passive immunization because it gives you the antibodies you need to protect yourself, collected from a large 10,000, 20,000 donors
Yeah.
in each sample of IVIG. And then it has the specific action of immunoglobulin on T regulatory. And
Yes.
that's the belief. The Tregs are being shown how to suppress an autoimmune process, how to eliminate those cells that are acting against our body. And another possibility is that there is in the collection of all those antibodies that are getting infused, there will be a few that will identify those autoantibodies that are acting against our body and will eliminate them, neutralize them. So it doesn't have side effects other than the,
Right.
the known
That's
one.
exactly what I was going to say. You took the words out of my mouth. The one thing, I tell patients this all the time. When I'm dealing with therapies, and, when we're on the front lines really caring for patients, not sitting in a research lab, I like things that have been around a long time. And I know from my immunology background, I mean, immunoglobulin has been around since the 50s or 60s when we
Correct.
treated the bubble boy, the severe combined immunodeficiency. So it really does have quite a good track record. You don't hear years later people, like even these biologics, people, rarely, but they're sometimes getting cancers or they're more susceptible to infections. I mean, you don't get any of this with immunoglobulin. It's just difficult to obtain. Sometimes there's shortages. It's unfortunately expensive in some cases. I do intramuscular. What I tell patients, Dr. Katz, it's interesting. When I've seen some chronic Lyme or chronic fatigue patients that I use it on, and again, I don't always know exactly what the organism is, but we give a lower dose because I'm not trying to replace their whole immune system. Not like the immune deficient kids. I'm just trying to get enough in there that I can modulate, that's your words, which I thought I liked, the immune system, so it doesn't sort of counter attack itself. But
it's very, very interesting.
Yeah.
And you're talking about how many grams?
Yeah, it's a much lower. It's probably a tenth of what you give with the IVIG.
So milligrams to
Yeah.
the magnitude of hundreds of milligrams,
Yeah.
not even a gram.
Right.
Very interesting.
Yeah.
Very interesting.
All right. So as we wrap up, because this has been fascinating, what hope can we give to patients who have been told they have a neurologic disease? Should they be hopeful that there's just so many good things on the horizon, or even now for them to get treated, whether it's for multiple sclerosis or migraines? I mean, is this a good time to be in neurology?
Definitely a good time, much better than it used to be, and it's continuing to evolve with big hopes in brain stimulation, non-invasive brain stimulation, and genetic therapy. You can find the gene that caused this disorder and you can fix it. So in both subcellular level and both the electric modulation, we can continue and develop treatment modes.
Wow, that sounds very exciting. Well, this has been terrific. Also, for my listeners, please stay tuned. In a couple of weeks, I'm actually going to have on neurosurgeon Dr. Theodore Schwartz from Weill Cornell. He has a new book out called Gray Matters, where he talks about what it's like to be a brain surgeon. So I think hopefully you'll find that really interesting. I want to thank Dr. Katz for his time today. Please, any of your listeners who like this podcast, please give us a thumbs up and subscribe to the podcast. So until next time.